So as I promised, we're going to do a little more thinking about dimensions of quality. And I want to say a little bit more about how I use these as part of the QI process, and then have you do some more work in your groups. So as we mentioned earlier, these are the dimensions of quality that you can work with. And I want to just walk through a little bit what each of them mean. So first we have safety, which we're defining here as the degree to which related care risks related to care are minimized. So this is the do no harm rule, and very important to think about. Now, while it's implicit, it's important to think about when you say, we're going to talk about this care, say it's prenatal care or obstetric care. Let's talk about safety. What kinds of things would be critical for safety? It gets people thinking about harmful practices or risks that they want to avoid. And that's a useful conversation. And if it's not prompted there, they might not quite go into so deeply, well, we want to make sure that infection isn't introduced, or we want to make sure that, something doesn't happen in transit that shouldn't happen, and so on. So this is why we go through each one. For access here, we're talking about geographic access, economic access, social, cultural, and organizational or linguistic barriers too. So anything that makes it hard for the patient to take advantage of care can be thought of as an access problem. And the reason, organizational sounds like a weird one, but I'll give you an example. I worked in one hospital that was fairly large, and one problem they had was that people would get lost in the process of care. Like they couldn't find, they'd say, well, we did a great lab test, and then they're supposed to go for this consultation, but people would get lost and not be able to find where they went to go because the hospital was a very confusing space. So no one thought about the linkages between those two parts of the care they needed. Effectiveness, we talked about. Are you using the most effective practice for your setting for a given condition? And then technical performance, do people do it well? Continuity, I want to say a little more than I did earlier. This means we're giving ongoing and consistent care as needed, including timely referral and effective communication. So among the providers. So this will get to the point of interprofessional collaboration we'll talk more about later. Professional is complex. And so and you'll often hear, and again, we're talking about our own challenges in the U.S., we'll often hear people say, well, everybody was really nice, but boy, they didn't seem like they talked to each other at all because they all came and they asked me the same questions and they didn't know what each other was doing. So continuity not only means that the patient maybe sees the same care provider or team member to some extent. There's someone in their system of care that is stable, whether it's the community health worker or a primary care doctor, but then also that there's communication among all the different people taking care of that patient. So there's a patient record that permits continuity. You can find out if a patient sees you. You can find out if they've been seen recently, and so on. So there's a lot involved in continuity. And for some services, it's more important than others. I think as the non-communicable diseases rise in importance, some of these continuity issues become even more important. We're not just managing acute episodes. We're managing a lifetime of care for someone. And so without continuity, it's hard to know when they're ready for that next step in self-care. For example, you can think about diabetes, and the different steps you're taking with the patient over time. If it's the same, if you're new every time, you don't really know when's the moment where, gee, I really need to emphasize exercise more. I need to follow up on what we talked about. We came up with a strategy for reducing salt intake last time. I want to find out how that's going. I heard that this patient's family was complaining about the food she was preparing when she was making it healthier. How can I follow up on that? If it's a different person every time, you can't get that across. And then compassionate relationships, very important. Trust, respect, confidentiality, responsiveness. So this becomes important for everyone, particularly important for vulnerable populations, for populations that might have a history of of historically marginalized experience. It's going to be harder for them to trust the healthcare system. We have this as a challenge in the United States. I know we do in many places that you can tell me you're going to take good care of me, but I'm probably going to wait till I've seen that happen in my community a few times before I trust you. And then the appropriateness, again, we're going to be thinking about the particular attributes of the patient. There can be appropriateness criteria related to gender, age, disability, and community context as well. So what is right for people? I mean, I'll give an example. This is a little bit controversial. Oh, in fact, this will be fun to talk about with you. We have a big campaign in our state about encouraging people not to co-sleep with their infants. Okay? Because there's some evidence from some studies that there are risks associated with sleeping with your infant, that they should have a separate crib. Well, a lot of people think that, those loving times of sleeping with your infant, it's normal. It's what they've always done. It's what their parents did. They never knew anyone who, it seems crazy to say you shouldn't sleep with your baby. So what do we do about that? How do you make that appropriate for people for whom co-sleeping might be their culture? I know in Ecuador, I work in an indigenous community in Ecuador, and I stay with the same family. And they have their traditional culture. They keep their language. It's amazing. But they also have modern culture. So they have internet and they have TV and they have American TV. And they said that one thing that always makes them laugh is when in the American TV shows people say goodnight and then they all go off to these separate rooms. They just think that is so crazy. Why would you go and sleep all by yourself and have nightmares when you could snuggle with your family in one bed? And so, we laugh about this, but it's a serious question. So what would be appropriate? How do you want to spend your time, counseling new parents? I'm not going to say the answer. I don't think there is one answer. I have 3 kids, and I probably slept with them a lot, too. So I don't know what to say about that. But that's an example where we face this challenge in a current campaign. Participation, making sure patients get a chance to participate in their care to the extent possible and appropriate. A lot of times there's 3 things that could work, right? So are you really making sure that what is easiest and preferred by the patient is done? I do a lot of work with highly vulnerable children. It's really important with teenagers. A lot of times we think about their parents as participating, but when someone is 17, there's a lot of decisions. Their parents are still making decisions with them, but you don't just wake up one day at 18 and able to make your own decisions. You have to be gradually eased into that. So a 10-year-old should get to choose what they want for lunch, probably, rather than their mom, right? And a 17-year-old probably, I remember when my son was 17. Yes? Well, I'm saying 17 is the end of childhood, so technically they're still a child, but if you haven't started easing them into things, they're not going to be ready for that morning when they wake up on their birthday. So I'm saying 17 is interesting because the child voice is a gradual thing. So for a 10-year-old, you wouldn't think it was appropriate to force them to wear what you thought they should wear. They might want to have some choices. On the other hand, you might not want to let them go on a long trip by themselves, right? When they're 17, I was going to give an example from when my son was, because he was almost 18. And I had read about this gradual, rights of the child and the gradual realization of it. And they asked him if he wanted a particular vaccine. It was the HPV vaccine, and that provides some protection of sexually transmitted diseases. At the time, it was like mainly for the partner. And I was all ready to answer, and I thought, wait, he's going to be 18 in 2 weeks. So I said, well, Evan, you have to read about this and talk to the provider and decide what you're going to do, because in a month you'll be making those decisions. So I gave my opinions and stuff, but he was the decider. So it's particularly with young people, but Again, with people with disabilities. That doesn't mean no decision should be made. As someone gets older, you don't pretend they're not in the room. They still can participate in everything they can, and if they're losing some abilities where younger people or their children need to step in, you want to make sure that that's only when necessary. So that's that idea of participation, this full realization of people's agency to the extent that is appropriate. And then sustainability. When we think about sustainability here, it means that whatever you're doing can be sustained by the local system. So, for example, if I was doing a neurosurgery global, partnership, I wouldn't want to just teach people how to do what I was doing and expect them to keep doing that when I'm gone if I brought a lot of the structural elements in. I would want to make sure the whole setting was transformed to support that care. So when you're thinking about a technology, you want to make sure the whole system is able to not only use it, but repair it, renew it, sustain it, in all those different ways. So this is what we'll be talking about. Now, why is it important to think about these dimensions? Well, first of all, when you use the dimensions, it allows people to come up with measurable, explicit expectations about care. And also it gives you a framework for then assessing what you're doing. And so we're going to do an exercise now that allows you to think about these very specific quality criteria through the lens of the dimensions. It also gives people a common language for individual groups to talk about their values. That should say identity, not identify. That's a mistake. Sorry about that. And then it also, so that means that if we've had a conversation about dimensions, later it becomes a shorthand. Well, let's remember compassionate. And then, okay, people will say, wait, I know what I'm talking about. Or let's remember safety. So it becomes a common conversation that people can bring to different aspects of care. The other thing is, a lot of times we get into what I call deficit thinking. We can only focus on what we don't have. And so when we're trying to solve a problem, we can't get these labs done. We need a laboratory, or we need this, or we need that. Focusing on the deficit of what's missing. But just because you know what's missing, it doesn't mean you're imagining what quality looks like. So imagining what quality looks like is more than just closing the gaps. And we're going to ask ourselves the question, what does quality look like, quite a few times in our group work now. So envisioning quality is a really key. You can't do something that you can't imagine or see in your mind. And then also it's grounded in evidence-based medicine. It gives us a chance to make that link between the evidence and what we're actually going to do. So these are the reasons why I think this is useful. And here's what we're going to do now. You have a template that looks something like this in your workbook, and I'll help you find it in a minute. But in the same groups that you've been in, I want you to think about a tool for developing some quality expectations or standards for something that is of interest to your group, whether it's infection control or hand washing or something that you care about. So you can spend a few minutes thinking about what you want to talk about. Maybe that's a common problem. And then for each of these, I picked 5 just because I wanted to make the exercise shorter. But you can talk about any of those dimensions you want. And for each one, think about, what does quality look like? Think about what you know from the scientific evidence. Think about your professional experience, your wisdom, right? And then think about what patient perspectives might be. Now, if you were really doing this in the team, you'd actually go to the library and look at the literature. You might actually consult with your whole team of clinicians. You might talk to a group of patients. But here, we're just going to imagine that. So what does quality look like? And think about those 3 parts of evidence-based medicine. What do we know from the science, from the studies? What do we know from clinical practice and experience? And what do we know from patient, the voices of patients? And then what does safety look like for this particular? So say we're talking about immunization. What does safety look like? Clean needle for every patient, preserved cold chain, having it in a secure environment. You can think of a whole bunch of things that safety? What does effectiveness look like? Well, you've chosen the right vaccine. You actually might put the cold chain there rather than safety. A lot of times we think about safety as things that mean immediate harm. And while it does produce a harm to give an ineffective vaccine to someone, we think more of that as effective. Although you'll see some things could go in more than one place. What about efficiency? Well, I'll give you an example of inefficiency. When I have 5 people in my family, and I like to get the flu shot. And in many of your settings, I probably could come with all 5 of us and say, we need flu shots, and you'd line us up and give us flu shots, right? Is that what you would do? If I came with my family, what would happen? What would happen in your setting?
So normally, if the patient, if the consumer wants, then we have to provide. But first, if you are talking about my settings, then we first access that whether it's essential to that group or not.
Mm-hmm.
That's the main thing that we first do.
Mm-hmm. So if everybody was supposed to get a flu shot as the norm, and I came, what would you do? Okay. So let me tell you what happens here.
Just as a family doctor face this.
Yeah.
What would happen, we have flu shot clinics.
Right.
And basically encourage our patients to come and get it that way. And if I was seeing a patient for some other reason, and they asked for it, I might give them that. But if somebody walked in with 5, I just have to explain, listen, it takes so much time for us to pull the charts and do all this.
Right.
It's inefficient.
Right.
And so could you please come back, on Tuesday afternoon at 4 o'clock.
Right. So in the case where I was seeking care, there wasn't any time, even a clinic, when we could all go because we had 2 adults. I went to a family medicine doctor. My husband had a different primary care doctor, and the 3 kids were pediatricians. So we had to go at 3 different times to get our flu shot. There wasn't like a family clinic you could go to, which was a little crazy. And I'm sure there's good reasons why, and it's hard to do these things well. But that's an example of, was it good quality? Absolutely. Did we make it work? Yes. Was it efficient? I don't think it was efficient for anybody because we were willing to line up and get our shots. There's issues with what the dosage and type were too. But anyway, these are complicated. Yes.
So one interesting aspect of this is capitalism. And Walgreens jumped in and said, we'll get flu shots, come in for $25. And for a lot of people, that's much more convenient than going to their physician because it's...
Yeah.
They're also open up early. They're open up late. No chart has to be pulled. They get their flu shot. And so that was a good way where they jumped in and actually provided a service that we did not provide well.
Well, and if we looked at the math on that, I'm not sure about this, but I know that there was a way that people could get reimbursed. It might have been efficient. It might have increased efficiency, depending on how it impacted. I don't know what all the impacts were, but there are times when those kinds of things work, and that is a little more like the way a campaign at a community level works. In some countries, they would just go out to the community and deliver it, So anyway, and then compassionate. So you can start thinking about this immunization again. Is it compassionate? Well, then you start to say, is compassion really important for immunization? Maybe somebody will say, look, you give a shot, On the other hand, someone may say, well, this might be the beginning of someone getting regular preventive care that they really need. I want to make sure that I reach out. I don't want to traumatize children who are getting their first shot. So again, or I want to make sure that if someone has a pre-existing condition where they can't get the shot, that I explain to them other ways they can be safe, and if they feel afraid about it, I reassure them. So there's a lot of ways that compassionate care would come into it. Maybe not as much as other kinds of conditions because it's a pretty straightforward procedure, but still worth thinking about. And then sustainable, you can have a similar conversation. What does the sustainable, immunization program look like? So that's kind of what I'd like you to do in your small groups is pick something and imagine what quality looks like. And when we do this to really prepare for a QI project, you have just little points or bullets under each thing. And instead of having a vague grope, quality is good, people get better, you start to have a lot of specific things that you can make sure that happen, put on a checklist, prepare people. So it is the specificity that is valuable. So let's look in our books. I think there's a worksheet Page 9. Is it page 9 in the back section? Okay, so go to the purple section, which is the middle section. And right after you were just reading, on page 9, there are the definitions of quality. And if you turn the page, you'll see a sheet that looks like this, and you're welcome to write it in if you want, to really think about what would quality look like. So pick something that you want to talk about and write it up here, and then start thinking about specific quality criteria for the different dimensions, and we can just kind of have a discussion about that. And then I'll call you back in for a few comments toward the end, and then we'll have some instructions about the lunch that awaits you. So I want to call you back to the central circle to just reflect a little bit. And I guess I think what I'd like to know is how were the dimensions useful to thinking about what quality looks like? In what ways? If you want to just share any small things from your group, or if you have other suggestions of how imagining what quality looks like. Well, I hope this just gives you a little flash of the value of explicit criteria and thinking with people, and not diving into problem solving, assuming that people can imagine what quality looks like, because they may not be able to. They may have a better vision of it than you do, but then great, then even if that's shared, it will improve, it will set the stage better for quality improvement.